where do we start with thromboinflammation? It's a word that has appeared over the last few years, and it means different things to different people. And I'm going to go through how different people see it. And I'm showing you the pig for a proper reason, but I'll come back to that. So if we look at journals and we have a look to see what the definition of thromboinflammation is, there are a variety of them. So these are two recent ones. The one on the right, the concept of thromboinflammation, is a particularly good article on thromboinflammation, which is freely downloadable. So I would suggest if you're interested, that's the one to go for. So on the left, we have a very long definition, and it says thromboinflammation is a condition characterized by the concurrence of thrombosis, inflammation, and vascular leakage bleeding, which induces and exacerbates each other, leading to tissue organ injury and death. And so that's a very loose, lazy definition. And on the right, it says inflammation and thrombosis are intricate and closely interconnected biological processes that are not yet fully understood and lack effective targeted therapeutic approaches, maybe. Thrombosis initiated by inflammatory responses is known as immunothrombosis. And then it also tells you about that coagulation can lead to inflammation. So where we are with thromboinflammation is two processes as far as I'm concerned. In fact, there's probably a third. And that's the fact we can have immunothrombosis, so the immune system causes inflammation, inflammation activates coagulation, and then thromboinflammation is the reverse. It's the coagulation pathways activating inflammation. And so it's a real reminder of crosstalk between immunology and coagulation. And when we look at immunothrombosis, we're usually looking at situations such as COVID, which I'll talk about, where you have huge numbers of cytokines who will lead to activation of a number of cells, and the key cells that need to be activated are those expressing tissue factor. And of course, once you activate tissue factor, you'll switch on coagulation. So you activate platelets, they produce extracellular vesicles, they're usually tissue factor carrying, monocytes, they will all lead to activation of coagulation. And then this version of thromboinflammation on this slide is really talking about what happens after you have formed a clot, in that some of the coagulation pathway will affect immunology and will lead to recruitment of other cells into the clot. And I think, for example, of the leaching out of thrombin out of a clot, it will cause activation of local monocytes that will move in to the clot and start the process of recanalizing the clot and healing it. So when we look at immunothrombosis, immunology leading to coagulation activation, we can extend that out to antibody-mediated thrombosis as far as I'm concerned, because that is immunothrombosis. That's where I actually started from. And we have a lot of antibody-mediated thrombosis. So we've got antiphospholipid syndrome, where we have antibodies that are directed against phospholipid and can cause spontaneous thrombosis. We've got acquired thrombotic thrombocytopenic purpura, acute TTP, where you've got an antibody to Adamets-13, so that we have very big von Willebrand factor molecules circulating that activate platelets, and we get platelet clots everywhere. And then we've got heparin-induced thrombocytopenia and thrombosis. I'm going to talk a bit more about that, and vaccine-induced thrombocytopenia and thrombosis, both antibody-mediated. More recently, we have had cases where people have a paraprotein, so they might have a level of IgG, IgM, IgA. They have maybe myeloma, or they don't have myeloma, they just have a monoclonal gammopathy, and that antibody has got some specificity against a plasma protein and will cause spontaneous thrombosis. And that's rising. There's a lot of articles on that in New England Journal at the moment. But the last one, which is where I started from, is antibody-mediated rejection. So when I started out, I finished my training and I didn't want to be a conventional hematologist, and I went to work in a heart and lung transplant centre, and I looked at the problems that they were having with hematology. And just to remind you that if you have got a blood group, you have got preformed IgM antibodies against other groups if you're A and B. So even a baby will have small amounts, if they're group A, of anti-B, and if you're B, you'll still have small amounts of anti-A, and the levels increase as you get older. So you've got preformed antibody, and so when you do a heart or a lung transplant or a kidney transplant, you must give the same blood group as the recipient. So the donor and recipient need to be matched. And what really sparked my interest was, unfortunately, many years ago, I did see a group B heart go into a group A recipient by mistake. And what happened? Well, the heart didn't beat for very long. It became very black very quickly, and it was full of microvascular thrombosis. So the IgM antibody and the immune reaction were sparking off thrombosis in all the vessels. And so I got really interested in that, and then I started looking at using pigs to put into humans, and we have exactly the same scenario in that you have got preformed antibodies against pigs from soon after you're born, well, really from the time you are born. And that's quite interesting. We have preformed antibody against all other animals, which is why all the early experiments hundreds of years ago where they gave pig organs or they gave sheep blood to humans were a catastrophe. So we looked, and there was a global move to try use pigs as donors. And so I got very involved in looking at hyperacute rejection, which is that phenomenon I've described in the A-B mismatch, very fast rejection of an organ. And we would take a pig heart, still beating, out of a pig, and we'd put it on a rig and perfuse it with human blood. And it would be rejected within 5 to 10 minutes. It would just gradually turn darker and darker and then stop functioning. And you'd look at the histopathology and it was all thrombosis. So those preformed antibodies were directed against glycosylation moieties on the pig endothelium. And it's an alpha-gal molecule on the endothelium to which the antibodies bind. And we know that the antibodies will cause complement activation, and complement activation will activate coagulation. Well, sorry, that is immunothrombosis, because you have an immune process leading to thrombosis. If you removed the antibodies, as we could, you'd still get rejection over the next few well, on the rig next few hours, because there would be other mechanisms coming in. So the macrophages would move in, the lymphocytes would move in, and they would spark off chronic rejection. So this is antibody-mediated rejection leading to complement activation, and I think this audience probably know a little bit about complement. You've got 3 pathways. You've got the classic pathway, which is what I'm talking about, where the antibodies activate C1, and you go through that cascade pathway. It's another cascade where you've got amplification. And at the end, the complement will form a membrane attack complex, which will drill a hole in the cell membrane, and the constituents of the cell will be released, and that cell will die. But at the same time, we know that complement will lead to release of small vesicles from cells, such as platelets and monocytes, which will have tissue factor on, so they will start the coagulation process locally. And in the same way, we know that thrombin will also activate coagulation. So we've got multiple relationships between coagulation and immunology, and it does seem rather a miracle that we're also healthy and that things don't go wrong so more frequently. So I think all thromboinflammation is doing is expressing what we've known for a long time, that immunology and hemostasis are intertwined. So if you activate hemostasis, you'll have an effect on the immune response. And similarly, if you activate the immune response, you will get activation of hemostasis. They are working together. And it takes you back to think about phylogenetically what was the point of hemostasis. And it was always said to be you got activation of fibrin and fibrin deposition to wall off invading bacteria in primitive organisms. So coming back to the different parts of it, and there are so many interactions, I can't go through them all, but I'm going to give you an example. So for me, the key problem with immunothrombosis is that you are dependent on tissue factor expression on the monocytes, on the platelets. So perhaps that should be a target in future inflammatory illnesses where you are getting thrombosis. We use anticoagulation, but it doesn't really work very well. And then we've also got netosis. Netosis will lead to activation of thrombin and also will lead to leukocyte trafficking and will affect the endothelium. The other player here is fibrinolysis. So I think it's very important to remember fibrinolysis developed a long time before the coagulation pathways. And what fibrinolysis really does in the tissues is allowing the cells to move, because when you produce plasmin, which is the goal of it, this is one of the most powerful enzymes in the body. It breaks down extracellular cement, allowing macrophages to move, allowing cells to move. And then within the blood, plasmin will break down fibrin and generating small fibrin degradation products. And the one that we tend to measure is something called a D-dimer, where there's 2 D molecules close together. So these pathways are also affected by inflammation too. So if you have an inflammatory response and you have high levels of interleukin-1, interleukin-6, you have increased production of PI1, which will change how this works. And I'll talk about that again in a minute. Oops. And then we've got platelets. I think there's a lot of people at this conference who are much more into platelets than I am, but platelets will interact with leukocytes, as we know. They can travel around together and they can activate them. and cause them to do damage. Now, all through this, we also have the endothelium. And in hemostasis, it's conventional to talk about the endothelium being the conductor of the hemostatic orchestra, because normally the endothelium is presenting a surface against the blood, which is telling the blood not to clot. And it can be activated by so many different things: thrombin, interleukin-1, tumor necrosis factor, whole host of cytokines, complement. And when it gets activated, we have a flip-flop of the membrane, and we lose a lot of surface molecules. So we lose things like thrombomodulin, so that we can't switch on protein C. We down-regulate various things such as nitric oxide production, so that we aren't getting the message out for the platelets not to aggregate. That comes away, and we actually produce platelet activating factor. So I came to endothelial cell activation through hyperacute rejection, and if you removed the IgM antibodies and you looked at chronic rejection afterwards, one of the key things about the endothelium when it's activated is that it increases expression of self. So it's expressing HLA molecules, and they're more expressed when you activate the endothelium cells. So really important in rejection. And then you've got the endothelial cells separating from each other so that you get fluid moving through, and obviously the changes in coagulation over the top. What everyone thinks about with endothelial cell activation is that the leukocytes can start sitting along the top of the endothelium, and then they will move through to the subendothelial tissues. So when we look at modern treatments, statins are really interesting. So statins, everyone talks about statins to lower cholesterol, but in actual fact, statins have an anti-inflammatory response. The whole of endothelial cell activation is dependent on a molecule known as NF-kappa B, and they downregulate NF-kappa B, and they will prolong your life. And for me, we've always been talking about a polypill to prolong life, and really ought to have a statin in it. Vitamin C, various other ones, and then we also stimulate angiogenesis during endothelial cell activation. So I'm going to talk about COVID and clots, coming back to VTE, which is what I talked about earlier in the week, and also to talk about immunothrombosis. And there are two forms of immunothrombosis that I will talk about. I am actually still very involved in COVID. I co-chair the World Health Organization COVID guidelines. So once a week we have a call, and there's always something new to say about the drugs coming through. But generally in Europe, COVID is on a downward fall, and the average COVID infection is now like a common cold. So I'm going to talk about acute COVID, and then this other form of immunothrombosis, vaccine-induced thrombocytopenia and thrombosis. So COVID, to remind you, is binding to the ACE2 receptor, which is present on the pulmonary epithelium and endothelium. It's also in the nose, and expression increases with age. So one of the reasons for children not having such bad problems, most people who get COVID have a mild infection, and they might feel unwell and have flu-like symptoms. They might lose their sense of smell for a little while, but they recover. And the problem with those first waves of COVID that we saw is that no one had any immunity to COVID, and about 5% or it depends on your underlying population, would go on to get COVID-19 pneumonia. And what we were seeing in the pneumonia, and this is a cross-section CT of someone's lungs, as you can see there's lots of white areas there, and there was a massive inflammatory response with the COVID, and a lot of cytokines and macrophages within that if you look at the histopathology. So how did we manage those patients? Well, why did they get admitted to hospital? Because they were hypoxic, because they needed oxygen. And we divided them up into moderate, so they could have some nasal cannulae to get oxygen, or if they were really hypoxic, we would have to ventilate their lungs and they needed mechanical ventilation. And then one of the effects we saw, and I'm going to show you, is this severe prothrombotic state due to the effects of the cytokines. And people who had severe COVID tended to have a pre-existing inflammatory state, and that includes increasing age. So as you age, you're more and more, you've got a prothrombotic state and your cytokines are slightly set at a different level. And then those who are obese, that's a very interesting story I haven't got time for, and then atherosclerotic disease and diabetes. So this here is, at the bottom, is a heat map of COVID and the different waves that we have had. And we're going through time. So this is the number of cases in the UK that were recognised who had COVID. And you have to remember, we didn't have testing until quite late. So that's an underestimate. So this is the alpha wave, as we called it, at the start. And then as time goes on, we had a delta wave. That was the following winter. There's a winter of 2020. And then we've got these little hills here, various types of COVID, but again, not causing so many problems. At the bottom, we've got a heat map of ages in the UK. So we start off with babies and we come out here to 90 to 100. And if it's blue, it's people who have died from COVID. So it very clearly shows you that we had a lot of deaths early on in the elderly from COVID, and the Delta wave was pretty awful. The Delta wave also seemed to affect pregnant women. We had a lot of pregnant women who we had to ventilate there. And then since then, we have had fewer problems because we have treatment. So there were big international studies that showed if you gave steroids early on, you could save people's lives. And then we use anti-IL-6 blockers. And then the vaccine came in round about here. So less deaths. And then if you look at these patients and their risk of having clots, this is the Swedish data. Isn't it amazing? You can produce data from a whole country. So they looked at all of their cases of deep vein thrombosis and pulmonary embolism and compared the cases in those who had COVID. So what you can see here is if you have mild COVID, very few cases of VTE, and the relative risk of having a clot was 2.8, so 280% times the background. But when you come down to those admitted to hospital and admitted to intensive care, we're talking about 30 times the background risk. When we look at pulmonary embolism, really, we've got very few cases again in those who have mild COVID. But once they get admitted to hospital, their risk goes up absolutely enormously. And we're talking about 200, 300 times the background risk. And then lastly, we're looking at bleeding risk. And because you're going on anticoagulation, bleeding risk will go up. Now, to a clotter, this isn't right. There's something wrong here, because for every case of deep vein thrombosis, there should be, or for every 2 cases of DVT, there should be 1 case of pulmonary embolism. And yet it's saying that the risk of pulmonary embolism is, well, it's 10 times the risk of DVT. And so what's going on? So how do we diagnose pulmonary emboli? Well, we do a CT pulmonary angiogram, and we look for areas of no flow on the angiogram. So what this is actually saying is that there were many more people who had areas of non-flow on their CT pulmonary angiogram than one would expect for the number of DVT. So this is not quite, there's something going on here. Oh, so I'm just showing this because any chance to show a picture of Ralph Fiennes, who's Voldemort. During the COVID pandemic, I was always at work, always thinking about COVID, and I was always lecturing about COVID. And I also did the radio, and I did a piece to the Today programme, which is our morning Radio 4 programme about COVID. And David Hare, who's a big playwright, heard me and wrote a play about COVID and quotes what I said. And I said, because it was so awful, looking after these patients because they were all so ill. And I said, it's almost medieval in what we're seeing. And he wrote down all my words. And he also wrote down the signs and symptoms of DVT, which is very helpful in a play. It went on in London, and it's been made into a film, and it will disappear into the abyss, never been seen again. But one chance at fame. Anyway, I met Ralph Fiennes because he had to talk about me every night, mention my name every night in the theatre. So, coming back to this problem in the lungs, what were we seeing in the lungs? And we recognized we were seeing 2 pathologies. So yes, we were seeing pulmonary embolism. And when we look at COVID and somebody being ventilated for COVID, it's the perfect recipe for having venous thromboembolism. You're immobilizing them, they're on a ventilator, they're not moving their legs, their blood is very sticky, and their endothelium is also upset. So we were seeing DVT turning into pulmonary emboli. But what we were also seeing was immunothrombosis. These patients, when they get ventilated because their lungs don't work, we call it acute respiratory distress syndrome. And we had known since 2013 that if you get acute respiratory distress syndrome, you get so much inflammation in the lung, you get areas of thrombosis. So that was why, when we looked at the figures, they said there were so many cases of pulmonary embolism. Actually, they weren't. We were seeing pulmonary emboli, but lots of immunothrombosis. So let me show you. We've got here, so I think I've shown you that one. Here we have somebody with bad COVID pneumonia. You can see all the whiteout. That should all be dark. It's a whiteout. But what COVID was doing is also switching on acute inflammatory response. And many of the coagulation proteins are acute phase proteins. So we looked at our first wave. These are the first 40 patients, 66 patients we saw who were ventilated, and we looked at their fibrinogen levels. Klaus fibrinogen is the functional fibrinogen. Normal levels in an adult up to 4, look at the levels that we're seeing. Can't believe I've actually seen somebody with a fibrinogen level of 10 grams per litre, and they survived. It's incredibly high, incredibly sticky, incredibly viscous, causing huge rheology problems. And we compared those who had changes on their scans against those who didn't. Actually, there's very little difference. D-dimer, which is the fibrin breakdown product, well, it's meant to be less than 0.5. I've had to use a logarithmic scale here. We've got tens of thousands, so huge inflammation. And these are other markers of inflammation. Again, we've got the normal range right here, down here for procalcitonin. Very, very high levels. And ferritin, we in our hospital, we use ferritin as our main acute inflammatory response protein, and we actually set it up so we get it turned around very, very fast. That was one of the first things I did in the lab in COVID. There's the normal values. Normal values are up to 50, and we were seeing levels of 10,000. And CRP, again, very high levels. So profound inflammatory response. And it comes back to this intertwining of hemostasis with the immune response. So just talking about thrombosis with inflammation. Before I went to become a transplanter, I was running clinics of where people have vasculitis, inflammation in the vessel wall. And there, again, they have thrombosis as a result of inflammation. And I think one of the things that made it that much worse in COVID was the hypoxia. So we were seeing people who couldn't maintain their degree of oxygenation. You're running, sitting there with a saturation of oxygen of about 98 to 100%. In COVID, we'd see people who'd drift down to 50, 60% near death. And even if you put them on a ventilator, you couldn't get it up. So you've got hypoxia as a stimulating factor to changes, and you've got the hypoxia inducible factor on the endothelium, which will lead to multiple changes, including upregulation of tissue factor and increased amounts of PI1. And of course, we now know that the SARS-2 virus can cause endothelial cell activation. So when we looked at immunothrombosis, it's easy to imagine all the cytokines around the vessels inducing local tissue factor and local thrombosis. And about the same time, people were getting very interested in NETosis, and we found incredibly high levels of products of NETosis in COVID. So we were amazed. As a physician, you've got patients dying in front of you, and you feel very helpless because you've got a new disease and we didn't know how to manage it. So it's emotionally very difficult. And then we were saying all of these bizarre, what we thought unique changes. But in actual fact, when you get a grip of the situation and you go back and you look at the literature, much of the changes we had seen had happened before. So these very high levels of D-dimer we were saying, we thought were unique. But then the people in Wuhan who had the first cases of COVID, you remember COVID came from Wuhan, had looked back at other patients they had ventilated for acute respiratory distress syndrome, and they had found that they actually had really, really high levels of D-dimers. So this isn't new. This was a marker of acute respiratory distress syndrome. And if you look at the literature, it seems like the lungs in acute respiratory distress syndrome will produce large amounts of urokinase type plasminogen activator, which will activate plasmin and produce these high levels. So when we look at what was happening in COVID, we had multiple problems. We had an acute phase response leading to those very high levels of things like fibrinogen, endothelial cell activation, fibrinolytic shutdown because of the inflammation, and yet we had those very high levels of D-dimer probably spilling over from what was happening in the inflammatory lesions in the lung. So this is not a situation where coagulation has broken down and we've got disseminated intravascular coagulation where anything goes crazy. In fact, it was a combination of responses to the immune changes, proper immunothrombosis. So one of the questions was, because we were seeing horrid deaths and difficulties, was this immunothrombosis more marked than people who'd previously had acute respiratory distress syndrome due to other viruses? And we had data. We run an ECMO unit at my hospital. We put people on extracorporeal membrane oxygenation if they really can't, if their lungs have really gone and you want to help them. And so we looked at all the patients that we'd put in the first few months on ECMO and compared them with the influenza outbreak that we'd had a few years previously, where we'd had to do the same. So we've got quite big numbers, 80, 51, and we are here looking at the number of lesions on the scans, and we have got many more filling defects. And then when we look at the little tiny ones, which would be local immunothrombosis, with influenza we might see 4 of them on a CTPA, but with COVID we were seeing 14 on average in every patient. So saying that there definitely is more inflammation in those first few waves of COVID. And then if we look at the bottom, rates of DVT, quite common when you take, you're putting a big cannula in the iliofemoral vein, you quite often have a DVT, 25% in influenza, but 50% with COVID. So a very prothrombotic condition, and probably the most prothrombotic state we have ever seen with a viral infection. So what could we do to mitigate it? Well, we knew we could give steroids. We did a big international trial looking at the use of heparin. And what we found, this is 1,000 patients randomized to therapeutic heparin versus standard of care, which would just be a little bit of heparin. And you can see, this is the Kaplan-Meier survival curves. There were really no different between the two. And yet, when we looked at those patients who were just on oxygen on the ward, we found that if we gave them full dose heparin, they had a survival advantage. A small one, but a definite survival advantage. And so this is from Brazil, other countries did different things. So they gave rivaroxaban, which is a new blood thinner, as a standard versus the standard of care, and they found no improvement in survival. And it did suggest to us that probably it wasn't the anticoagulant effect that was benefiting the patient, but also the fact that heparin is a major anti-inflammatory drug. So we know heparin switches off complement, and maybe that was what was causing the effect in the COVID patients. For the platelet people, there was a big trial of aspirin in the recovery trial, and aspirin didn't benefit the patients at all. There was no improved survival, and in fact, there was a big bleeding problem, as you do get with aspirin. So we stopped using aspirin in those patients. So this is where we'd got to in August 2022, and really it hasn't changed very much. Just to use standard doses of heparin in the critical care patients. Consider full dose heparin in the moderately ill patients, which is the ward patients on oxygen, and not to give them an antiplatelet agent. So one of the things that came out, which was a cause of much discussion, was that we had given a drug in a clinical trial and we had a different effect of the heparin in a different group of patients with the same disease. And no one had ever seen that effect before, because normally you give a drug and you compare it with placebo and you just get the same effect. And so it did make people think about how are we going to run clinical trials in the future if we give a drug and it might have a different effect in different patient groups. So that has led people to think we need to run even bigger clinical trials than those that we currently do. So we're now moving on to vaccine, and I mean, when the vaccine came out, it was amazing when you look back, because COVID had arrived a year previously. Not only had they made vaccines, but the vaccines were being produced in huge quantities and ready for use around Christmas 2021. Amazing. And for us in the UK, we were dependent on two vaccines. One was the AstraZeneca vaccine, and the others were, well, we used Moderna and Pfizer, which are RNA-based vaccines. And we started to see odd cases of people with multiple thrombosis. And these were two that came to my hospital. So the first one was a 38-year-old. She'd been vaccinated 14 days previously with the AstraZeneca vaccine. I use AZ for short. And she had a severe headache, and she was a little bit knocked off, and that her Glasgow Coma Scale, which should be 20, it was only 14. She had a venogram which showed she had an extensive cerebral venous sinus thrombosis, so all the large veins in her head were thrombosed, and she had a pattern of changes that we kept seeing. She had a very low platelet count, very high levels of D-dimer, and a low fibrinogen. And we admitted her and started treating her, but she had a massive intracranial hemorrhage and died. And then this is other man. He was 41, vaccinated with AstraZeneca. He presented with ischemic legs 6 days after the vaccine. Again, this picture of very low platelet count, high D-dimers, and a low fibrinogen. And we'd already, at that stage, there were international calls between all the experts in thrombosis saying, what are we seeing? And in 2 centres in London and also in Germany, we'd recognised that there was an antibody associated with this problem in these patients. This was very similar to the antibody we see in heparin-induced thrombocytopenia, and we treat that with intravenous gamma globulin, and we started treating these patients with intravenous gamma globulin. And we managed to save this man's legs. He went back to theatre twice because we removed all the clots, and then he rethrombosed, and so took him back and did it a second time and gave him big doses of an anticoagulant called argatroban the second time round. So this is another new phenomenon. In the UK, we knew we were big users of the AstraZeneca vaccine. AstraZeneca had used the work of a vaccine centre in Oxford, and it was the British vaccine and all that. So we were seeing large numbers of people who had this type of problem. And we didn't really know what to do. Yet another new disease, just like COVID. How do you manage a new disease? So we, as a group of expert haematologists, formed a daily Teams call that people could dial into and could talk about any case that they had in their hospital. We started that in March 2021, and there was Marie Scully, Sue Pavard, Mike Macris, always on Twitter, Will Lester, me, and Catherine Baggett, who's a Scottish thrombosis expert. And every day, one of us would chair a meeting, and people would dial in from a hospital, wherever they were, and present their case to us. We discuss the diagnosis and then talk about the treatment. And this allowed us to develop living guidelines, which we put on our British Society of Haematology website. And we had to work with Public Health England to pool all the data. So it was really important to pull the data together, and we had a lot of Teams meetings, learning as we went. And so we were very quickly able to work out what was going on and what the best treatments were. A lot of people got very frightened after the vaccine. So in April, our regulatory authorities went public with the fact that people were getting multiple clots after the AstraZeneca vaccine, and our emergency departments were full of people who had a headache after they'd had AstraZeneca. And so we had to devise an algorithm for our emergency physician colleagues so that they knew how to manage these patients. Eventually, our guidance was converted to our national guidance and stayed on the website until all this came to an end because we stopped using the vaccine. So we were able to define the phenomenon, and we called it vaccine-induced immune thrombocytopenia and thrombosis. That was the international term. So we all agreed that was probably the right way to look at it. And these patients were having thrombotic events, quite often multiple, 5 to 30 days after vaccination. Now, for someone to develop an immune response to something, you need at least 5 days. So that was consistent with the immune etiology. They had low platelets, and they also had positivity for an antibody to something called platelet factor 4. And so we had these 5 criteria, and we could say it was definitive fit if they had all the criteria, or probable if they had 4. On the left, on the left, we have got the graph of how they presented, and 50% of them had major thrombosis in their cerebral veins. And then they had splanchnic vein thrombosis. A few of them had classic DVT-PE. Some had portal vein thrombosis. Really quite bizarre episodes. So I need to come to the pathophysiology. So we've known about heparin-induced thrombocytopenia for a very long time, since we've been using heparin in the 50s. So paradoxically, heparin can cause thrombosis in a few individuals. And what is happening is that heparin can act as a haptin, and it combined with something called platelet factor 4. Now, platelet factor 4 is probably well known to everybody here, but just for those who don't, it's a molecule. It's coming out of alpha granules of activated platelets, and it's responsible to opsonize negatively charged cells such as bacteria. And it also combined with high affinity to heparin and inhibit it. So, So here we've got heparin here we've got platelet factor 4, and you develop an antibody to the 2, and the antibody will bind to the platelets through the FC receptors on the platelets. The platelets are activated, and you get thrombosis through release of the procoagulant microparticles and all the other things that platelets do. So you get thrombocytopenia because this particulate matter will also go to the spleen and will be destroyed. What's happening with the AstraZeneca vaccine is that it's an adenoviral vaccine, which means that you've got an adenovirus carrying what it needs to carry, the neoantigens, and it looks like from the work of Granacha is that there is an interaction between platelet factor 4 with the vaccine. So we've got I think the red is the vaccine binding to platelet factor 4. And we're getting that same process. We're getting a neoantigen, which is causing an antibody to platelet factor 4, and we're going through that same process of thrombosis, immunothrombosis. So we had done a lot of clinical work. We showed that, yes, we give intravenous gamma globulin. The worst ones we actually plasma exchanged, and they definitely did better. You can see those, the red ones who got plasma exchange survived better than those, the black ones. Sorry, the other way around. The black ones received PEX and survived better and got a better restoration of platelet count. And we've been following this cohort, so we've got about 350 patients who've had VIT and survived. And we followed up, and we find this antibody, which is still present up to 150 days after the actual event, but doesn't appear to be pathogenic that far out. So there's been a lot of work on it, and people have looked at where the antibody is binding on platelet factor 4, and they've shown the epitope for the binding of the antibody is different in VIT and HIT. And we have to keep a sense of proportion about this, because in actual fact the VIT only occurred in 1 in 50,000 to 100,000 of people who got this vaccine. And when we look at the thrombosis rates in people who have had COVID, they're so much higher. So we look at the rates of cerebral venous sinus thrombosis. They're really high with COVID itself and much lower with the vaccine here. But that's not the end of the story, because since that time, we have had reports of cases who have had the same picture of the vaccine-induced thrombosis and thrombocytopenia, but have not had the vaccine, but they've had adenoviral infections. And so this is a 6-year-old boy. He presents with a low platelet count. He has a cerebral venous sinus thrombosis. He gets treated. They find an antiplatelet factor 4 antibody and gets treated in various ways. This is an older woman who presented with a low platelet count, again presenting with multiple thrombosis, and after a stormy course survives. So somehow we have missed, looking back over time, cases who have had spontaneous VIT. We haven't recognized it as a phenomenon. And I can think back over my career, and people would present with a very low platelet count and a lot of thrombosis. And you think, oh, it must be antiphospholipid syndrome, and they get treated in a certain way, very similar to what we do for VIT. But clearly, they have this disease. So this is something that can happen spontaneously. You can form these antiplatelet factor 4 antibodies after a viral infection. And the other thing to say about the people who had FIT is they have had a very difficult time, and we've done some psychological studies on them. It's very hard if you've had the vaccine to protect yourself, to protect your friends. You're being told to do it. There's a national program to do it, and yet you have these major thrombotic problems, some of which are absolutely life-changing and they will never work again. And in the UK, we have a vaccine compensation scheme. You can get £120,000 if you've had more than 60% of your body damaged by the vaccine. Now, what 60% of the body means is interpretable by lawyers only. It means losing a couple of legs, and that it doesn't cause that type of injury. So there's a lot of medical legal action at the moment against AstraZeneca to sue them to get money back for some of these sufferers. So let's come back to thromboinflammation. What is it? Well, for me, we've got those two things. We've got immunothrombosis, the antibody causing thrombotic problems. I think it's a much wider term, as I've shown you. You can include hyperacute rejection. You can cause antibody-mediated disease. And then thromboinflammation, how some people use it, is the effects of hemostasis causing an inflammatory response. And I'll stop there. I'm sorry about my voice. I don't know where I've left it. Must have been at the meal last night. Thank you.
Thank you very, very much, Beverly, for this very nice talk. Questions?
Just hello, yeah, hello. When you say sticky blood, I like this term as a physicist. So you said at one point sticky blood that is more viscous, and then suddenly you use the mechanics term. So I wanted to know, for sticky in the sense of all the coagulation cascade and the biochemistry, or sticky in the sense of mechanics, and I would like to know a little bit more about that.
Okay, so sticky blood is something I use when I talk to lay people, and I started to find I use it when I talk to professionals as well, because it explains what's happening in a prothrombotic state. So you've got an increase of some key proteins, and they will have an effect on rheology, and the blood will be more viscous. But there are people here who could talk about that.
Indeed, so
much better than I can. Peter can do that.
Aggregation induces a higher level of viscosity at very low shear rates. So when you say sticky, you're talking about the blood elements that stick to each other.
So I'm really
like aggregation?
Sticky. You can exchange for prothrombotic state.
Okay, so this
yes.
part of the sticky.
Sorry, I shouldn't use the word sticky, should I?
It's like clot and thrombosis, you know.
I have maybe a stupid question. So will tell me, what was the advantage of nature to come up with a solution where the immune system and the hemostasis systems are cross-linked that way? I mean, is there any advantage in this? Because you see what I mean? What you told us is that.
So why should they be separate? So we teach them separately. So everyone thinks about them separately, but they grew up together. So therefore, they will naturally influence each other. And maybe by separating coagulation from immunology, we have caused the problem ourselves, haven't we? Because they're just molecules talking to each other. So, I mean, thrombin, think about thrombin. It can activate platelets, leukocytes, endothelium. It's a cytokine, isn't it, really? And yet it's the important molecule in the coagulation cascade. And it can cause thrombosis, but it will also, by binding to thrombomodulin, will cause anticoagulation. What a molecule. It's multifunctional. And the more we learn about hemostasis, the more we learn that all of the molecules in different situations will behave in different ways.
Yeah, but the fact that those molecules have many, many different effects, this is the results of an optimization by nature over many millions of years. So
it makes you believe in evolution, doesn't it?
Do you see
some may believe more in God, whatever your way of thinking.
Do you see any advantage that those two systems are linked that way, or is it only you observed it already? Okay, but do you see any advantage in it?
So you're talking to me because you've been taught there's hemostasis, there's immunology. I'm saying to you that's wrong. That's not the way. So they're all together, aren't they?
Together. Okay.
And we could probably split them in a different way, couldn't we, if we'd come at it differently?
Any other?
I don't have a question. I just want I just want to thank you for your presentation, because the subject was very complex, and as you told it perfectly, we teach hemostasis and inflammation separately, and COVID was a disease which reminds us that it worked together. And also I remember when we had the first patients, we were waiting for more disseminated intravascular coagulation, because the first papers
came out of Wuhan, and they said all of these patients will have disseminated intravascular coagulation. Well, when you're dying, your coagulation system fails and you do have disseminated intravascular coagulation. And when you looked at those people were on death's door, weren't they? But the earlier changes of COVID meant they just had very sticky prothrombotic blood.
Yes, I totally agree. And when we first saw the patients, we saw that there was such a high level of inflammation.
Yes.
So
you were here you were in Paris.
Yes, I was
at the
Paris.
time. Yeah.
Thank you very much for this great talk. I had a question. How could you explain that cerebral veins are more prone to get thrombose rather than peripheral legs veins?
So I've just written a big review of that, and when we look at cerebral venous sinus thrombosis, it's a really interesting disease. It's mainly affecting women, and estrogens are the driver. So we see it more commonly in pregnancy, in people on the pill, in people on hormone replacement therapy, women who have polycystic ovaries, women who are obese. So that it's that group outside. So there's obviously something about the cerebral veins that maybe they have estrogen receptors on them or something, I don't know. But why COVID and the vaccine has pulled out cerebral veins, I don't know either. And it's a reminder we don't really understand the endothelium of the cerebral veins at all. Nobody really studies them. So that would be a lovely project for someone to do. But if you look at anticoagulation in the cerebral veins, they are probably reliant on a slightly different set of proteins. So I don't know. I could give you some theories, but we don't know why.
Thanks a lot for your presentation. Probably you said it already and I missed the information, but did the patient that got thrombosis after AstraZeneca had kind of, so why those specific patients got, did they have any modification or like?
So when we first saw them, we thought they must have a prothrombotic state, they must have some risk factor. So we didn't give AstraZeneca to those who'd already had thrombosis and were on anticoagulation, and we realized it wasn't that, and a lot of people had no predisposing factors. So we have collected all the DNA from the 350 cases that we have who are survivors and from some of those who died, and they have done a genome-wide analysis, and we can't find any predisposing factor. So it's a good question, and there's no answer yet.
Thank you for the lecture. Just maybe it's a naive question, but I heard a lot like people who just had COVID also had like some problems during a dental procedure, maybe months and even year after. And like it was always undetermined the cause, but like doctors in my country were talking about the connection, maybe it was some secondary effects. So depending on that, I wanted to ask the people who had thrombosis after the vaccine, did they have COVID like in a heavy way maybe before having the vaccine?
No.
Okay.
So that's all been looked at. They've all been looked at in all sorts of different ways, and no, there's no evidence that they just had COVID and then they had the vaccine, no. And I'm not quite clear what you're saying. So there was a lot of misinformation and confusion about COVID when it was happening. So you have COVID, you have a slightly prothrombotic state for a couple of weeks afterwards, and you go back to normal, and you should have operations and dental extractions once you've got better, as you would after any viral infection. You wouldn't go with pneumonia to the dentist, and you wouldn't go with pneumonia and have an operation. You'd wait till you got better.
Any other comments or questions? No? So, thank you very much.
Thank you.